Hi, I'm Dr. Kiran Keshwara, Dentolegal consultant at Dental Protection, and welcome to Riskbites, a series of podcasts created specifically for dental practitioners in Australia. Riskbites looks at the key dental legal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. In this episode, we're going to be chatting with my colleague, Dr. Annalene Weston. So, Annalene, this title, The Elasticity of Truth, interested me when I saw it. What is the elasticity of truth?
Thanks, Kiran. Truth in many ways could be considered to be a rigid and fixed concept, as surely there's only one truth. But this belief is predicated on the concept that truth is linked to fact.
Isn't it?
Well, you'd think. But no, the issue with a rigid truth is that every individual's perception of the facts differs dependent upon what they've experienced, what they believe they've experienced, and critically, what they want to believe they've experienced. So is truth then a rigid and immovable object or more elastic like a rubber band?
That's an interesting perspective. And if the truth is elastic, how far can the band as such be stretched before it snaps? And do we, as clinicians, ever get stung by the recoil?
And there, Kiran, is the million-dollar question.
So, taking each factor which influences a person's concept of the truth in turn, what do you mean by difference of experience?
Okay, Kiran, so how many times have you had a reasonable conversation to find out after the event that the other person has heard something completely other than that which you'd said? Skilled communicator as you may well be, many occasions can and will arise whereby the message that you believe you've transmitted differs vastly from the message that's been received. Now, many factors seep into this, some from you, some from your surroundings, and some seated in the recipient themselves.
Yeah, true. And if we're honest with ourselves, are we always giving our undivided attention?
Well, exactly. Because even if you're not sat with your phone in hand, are you really listening? Or is your mind wandering across your perpetual to-do list, your worries, your woes, or places you would much rather be, worrying about the patient that's waiting in the waiting room and how late you are now running? Loose language and rushed or lazy explanations have landed many a practitioner in hot water when they find the patient didn't really understand the meaning of the risk that eventuated, and therefore they had no consent.
Yeah, and it's important to consider if your recipient actually is listening too, isn't it?
Absolutely. And whether they're even able to, because if your environment is noisy and bustling with incessant distractions, are you setting either of you up for success? Like if your surroundings are really frenetic. Attention's a finite resource, and you need to hold firmly in your mind that many patients do not bring the best version of themselves to the practice due to anxiety and fear. And when we're fearful, we're hardwired to shut off our higher level thinking to allow our amygdala to drive the bus. The corollary of this is a decrease in our ability to learn new things because we're primed instead to respond to danger. So if you then add distraction or overly complex or inherently lazy explanations into the mix, we have there a recipe for disaster.
Indeed. What about perception of experience? What do you mean by that?
Well, perspective's everything, isn't it, when it comes to forming a point of view? And in some instances, a patient can genuinely believe that they've been harmed by treatment despite all evidence to the contrary. And we see this all the time, don't we, Kiran, in our role?
Yeah.
And this is termed a perceived injurious experience, or a PIE, a PI. Now, PIs can quickly transform into an articulated grievance whereby the patient not only believes that you have harmed them, but will move to verbalize this in a name and shame manner. And this has aptly been termed naming, blaming, and shaming. So oftentimes these beliefs can springboard out of the Karpman drama triangle, whereby the patient for whom you've tried your absolute hardest turns on you, and all your effort, kindness, and attempts to go the extra mile count for naught and are bound to hit you squarely in the face.
Yeah, and I guess this is one of the reasons that it's been said that you will never win an argument with a patient.
Yeah, that's right. Because if a patient's formed a strong view that they've been wronged, they are unlikely to take your word that they were not. And as their truth now, of course, has become to them absolute. In these situations, the involvement of an independent third party, such as the regulator, is not to be feared, as these are often the only people who are going to be able to influence that patient's point of view.
Yeah, true. We all fear an ARPA notification, and it is, of course, scary. But with patients who are hell-bent on an unreasonable outcome, ARPA's intervention can really be a blessing. What about belief of experience? Do you mean people choose to believe the wrong thing?
Well, essentially, yes. But it's unconscious, right? Because it doesn't always serve us to face the truth, either because the truth hurts or because it doesn't get us what we want.
True.
So on these occasions, individuals may cling to their own version of events, knowing deep down inside the dishonesty of this because it suits them to do so. But more often than that, people actually lie to themselves or convince themselves of the facts because admitting that they're wrong or bending to compromise is just a push too far for them. So sometimes they don't even know that it's not true because it's their truth, right? They've come to believe that it is.
And sometimes if you repeat a lie often enough, it becomes the truth as well, doesn't it?
Right. Yeah, absolutely.
Yeah, when we help members, Annalene, I often find that those who receive a complaint which is a flagrant lie find it incredibly challenging.
Yeah, it really is.
And so what can we do to protect ourselves from others who approach the facts with a flexible view of the truth?
Well, first and foremost, Kiran, records can be everything. As proceduralists, as you know, we're highly skilled at documenting the procedures we perform. Equally, we're often appalling at documenting the discussions we've had with the patient. And if there's a difference in truth, this usually lies with what was said rather than what was done. The unpopular but rigid truth is that the only way to evidence what was discussed with a patient is through your clinical records. So time needs to be taken to consider how these discussions can be captured well. And if you're unsure, we of course have resources on our online e-learning platform which can help you.
Yep. People often tell us, Annalene, that they worry that giving the patient airtime on a grievance is going to actually make it worse. How would you respond to that?
I think, Kiran, and I'm sure you would agree with this, that we all need to remember that listening to a patient's point of view isn't the same as agreeing. There's often a window of opportunity where a patient can be brought back on side, but it does involve actually listening to what they have to say, even if you don't agree. And I'd say never fear that letting someone air their grievance is in some way agreeing with their point of view.
Yeah, and we all like our feelings to be validated, don't we?
Yeah, we do, particularly when we're feeling emotional. And it's not unreasonable to afford your patients this respect. Utilising active listening skills is the critical factor to successfully negotiate through the difficult conversations. And I'd also say in these situations, it's best not to take it personally.
That's really hard though, isn't it, Annalene? As while people are, of course, entitled to their own opinions, even if they don't align with our own, it can feel hurtful and downright offensive when someone doesn't agree with that perspective or actively opposes it.
Yeah, absolutely it can. But getting upset about this not only is going to cause you more grief and drama in the end, and it actually resolves nothing. Perhaps consider seeking feedback from a trusted peer so you can use the disagreement of truth as an opportunity for learning and growth. But apart from that, worrying and mithering about the situation is not going to serve you at all.
Annalene, what about occasions where the person is stretching the truth is in fact the clinician?
Yeah, I'm really glad you asked about that, Kiran. And regretfully, this can and do occur. And as you know, is very, very dangerous. As professionals, we're held to a higher standard than our patients, with inherent responsibilities such as the duty of candour, the obligation of open disclosure, and the requirement to be honest to be deemed to be a fit and proper person, to be suitable to hold registration. Stretching the truth, whether that be in the information we give patients, the documentation we keep, or the items we claim, is not always something we can do, as the consequences to our reputation and registration can be severe and even catastrophic in nature. So in summary, while the truth may indeed be an elastic construct, dependent on one's perspectives and beliefs, as professionals, the elasticity of truth is not something we can afford.
Thank you, Annalene. And thank you all for listening, and we do hope that this podcast was helpful to you, and we look forward to sharing more guidance with you in the future. If you like Dental Protection Podcasts and would like to hear more, please subscribe and leave a review.